Your patient's hands go numb for no reason. A week later, her vision blurs in one eye. Then it's fine again. Weeks later, it's back. Different symptom, different spot. Is this all in her head? No, it's her wiring. Somewhere in her nervous system, the insulation is failing. Welcome to Demyelination Made Simple. By the end of this video, you'll know exactly why that happens and how it becomes diagnoses like MS and Guillain-Barré. Let's get into it. Myelin is insulation. That's it. Think of the plastic coating on an electrical wire. Strip it away and the signal leaks, slows, or dies. Your axons work the same way. In the central nervous system, oligodendrocytes wrap that myelin, one cell insulating segments on several different axons, like one electrician wiring several houses at once. In the peripheral nervous system, Schwann cells do the job. One cell, one segment, one axon. Either way, the myelin isn't continuous. It's wrapped in segments with tiny gaps between them, called nodes of Ranvier. And here's the elegant part. The signal doesn't crawl down the axon inch by inch. It jumps, node to node. That's saltatory conduction, basically nerve hopscotch. Fast, efficient, and it barely costs any energy. Healthy insulation, fast signal. Now strip that insulation. Damage the myelin and current leaks out between the nodes instead of staying contained. The signal that used to jump cleanly now limps. Here's the nursing piece. When conduction slows, the message still might arrive, just late. When it blocks completely, the message never shows up at all. That difference shows up in your patient's exam. Slowed conduction, numbness, tingling, fatigue with activity. Blocked conduction, weakness, vision loss, a reflex that's just gone. Same broken wire, different degree of damage. So what actually damages the insulation? In multiple sclerosis, it's the immune system, attacking oligodendrocytes in the myelin they built, in the central nervous system only, brain, spinal cord, optic nerves. The attack leaves behind scar tissue. We call it a plaque or a lesion, scattered wherever the immune system struck. And MS doesn't hit once. It's disseminated, new lesions in new locations at different points in time. That's actually baked into the diagnosis, and we'll come back to it. For now, MS is autoimmune, CNS only, and it damages multiple places at multiple times. Here's where lesion location becomes your best diagnostic clue. Optic nerve involved? Optic neuritis. Painful vision loss, often one eye. Sensory pathways in the spinal cord? Numbness, tingling, that electric shock sensation down the spine with neck flexion, Lermite's sign. Motor pathways? Weakness, spasticity, and abnormal gait. Cerebellar tracts? Ataxia, tremor, poor coordination. Autonomic pathways to the bladder? Urgency or retention. And fatigue. Almost every MS patient has it, because even a lesion that doesn't fully block a signal still makes the nervous system work harder to send it. One disease, but it looks completely different depending on where the plaque landed. That's why MS can masquerade as 10 different conditions before anyone puts it together. Here's a phenomenon that trips up a lot of new nurses. Your MS patient takes a hot shower or spikes a fever, and suddenly their vision blurs or their leg gets weak again. Did they just relapse? Probably not. This is Uhthoff phenomenon. Heat makes already damaged, poorly insulated axons conduct even worse, temporarily. That leaky wire leaks more. The signal that was barely making it through now fails completely. But cool the patient down, and function often returns. Uhthoff is not a new lesion. It's a temporary conduction glitch. That's your teaching point, and it's your intervention. cooling strategies, avoiding overheating, and reassurance instead of panic. So, how do we actually diagnose MS? Not with one test. It's clinical reasoning built around dissemination in space and time, lesions in more than one location, showing up at more than one point in time. MRI is the workhorse, looking for plaques scattered through the brain and spinal cord. A lumbar puncture can support the picture too. Oligoclonal bands in the CSF suggest ongoing immune activity in the CNS. And just as important, we rule out mimics that can look similar. As the nurse, you're not the one making this diagnosis, but you're the one collecting the story. Which symptom, when, how long did it resolve? And that story is half the diagnostic puzzle. Quick pause. If you're taking notes, jot this down. Insulation, leak, dissemination in space and time. Those three phrases will carry you through most MS exam questions. Stay with me. GBS is next, and the contrast is going to make both diagnoses click. Let's flip to the peripheral nervous system. Guillain-Barré syndrome, or GBS, is also demyelinating, also immune-mediated. But here, the immune system attacks Schwann cells on peripheral nerves. It's often triggered by a recent infection, a GI bug, a respiratory illness. The body finishes fighting it off, then mistakenly turns on peripheral myelin. The hallmark? Ascending weakness. It starts in the feet and legs, climbs upward, legs, then trunk, then arms, sometimes the muscles of breathing. Reflexes disappear early. That's areflexia, a big clue. Watch closely for two things: autonomic instability and respiratory failure, because if weakness climbs high enough to reach the diaphragm, your patient needs ventilatory support fast. Diagnostically, a lumbar puncture often shows albuminocytologic dissociation, high protein, normal cell count in the CSF. Treatment is supportive, plus immune therapy, IVIG, or plasmapheresis to shorten the course. Your top nursing priority: monitor respiratory status closely. That's what kills in GBS if it's missed. Let's put these side by side. This contrast is pure NCLE gold. MS is central, brain and spinal cord. GBS is peripheral, nerves outside the CNS. MS is typically chronic and relapsing. Symptoms come and go over years. GBS is typically acute and monophasic, one attack resolving over weeks to months. MS symptoms follow wherever the lesion landed, could be anywhere. GBS follows a pattern, ascending bottom to top. Here's the mnemonic: MS is scattered, GBS is a staircase. Scattered lesions wherever the immune system strikes versus one clean climb from the feet up. Central and unpredictable versus peripheral and patterned. Let's bring it home. Myelin is insulation. Damage it, and conduction slows or blocks. In the CNS, that's MS. Autoimmune, disseminated in space and time, symptoms tied to lesion location, with heat as a temporary conduction stressor called Uhthoff. In the PNS, that's GBS, often post-infectious, ascending, and a respiratory emergency waiting to happen if you're not watching. Time to test it. Question 1. Your patient's reflexes are gone, and weakness started in the feet and is climbing. MS or GBS? GBS. Ascending weakness, areflexia. Question 2. A patient's vision worsens every time she takes a hot bath. What's happening? Uhthoff phenomenon. Heat, not a new lesion. Question 3. MRI shows lesions in the brain and spinal cord that appeared months apart. What's that concept called? Dissemination in space and time. Question 4. Which patient needs urgent respiratory monitoring? Your MS patient with optic neuritis or your GBS patient with ascending weakness? The GBS patient. Always. Did this finally make sense? Like, subscribe, and part 2 is coming next.